This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended. A 60-year-old man with an intumescent cataract and a pupil which is mid-dilated is posted for surgery. So I'm expecting high intralenticular pressure in this patient, and the rhexis is going to be challenged. And let's see how things turn out. Pupil is not fully dilated. The two side port incisions are made, so we have got quite a long intercorneal tunnel. The left side port is now being created. Time to stay in the intercapsule. A 1 ml syringe contains the air bubble and the dye in the same, and the air goes in first, followed by the dye. So just want to restain the capsule because we want the staining to be done well. So it wasn't staining well in the first place. I'm just going to redo the staining. Maybe about 8 to 10 seconds later, it is being washed off. Dispersive OVD is placed into the antechamber, burping out the air bubble. Time to create the main incision. The globe is stabilized by using a second instrument. Initial limbal groove is created for the triplanar incision. 2.8 blade is used. The blade just first traverses about 2 mm into the cornea and then changes direction to perforate the Descemet's membrane and enters into the antechamber. So now we have a 2.8 mm incision. Time to perform the rhexis. Now, anticipating a very high intracapsular pressure, my strategy is to do a two-stage rhexis in this eye. I'm just trying to refill the chamber with OVD just to flatten the intercapsule a bit. So my only concern is that the intercapsular tear should not run away to the equator as soon as I puncture it. So using the forceps, I make a small puncture. There is just a small aggressive fluid, not much. And then holding the capsule, I'm just trying to make a very tiny rhexis. So the situation is such that I'm unable to complete the rhexis. I feel that the AC is shallowing. I come out, I'm injecting OVD. Just pay attention to where the cannula is placed. It is placed in the periphery so that the capsule is flattened rather than injecting into the center where the opening is there. The capsule is again held with the forceps, and I could successfully create a small rhexis. So now is the time to go ahead and do a decompression of the bag. It's important that the decompression has to be done quite well, because if the swollen cortex continues to remain inside the bag, there's always a risk of the tear extending to the periphery when you're trying to do the secondary enlargement as well. The choice of instrument always is the phaco tip, because it can suck out more lens matter quickly, and also the thicker lens material, which has a consistency in the epinucleus, can be more easily aspirated through the wide bore phaco tip rather than the aspiration cannula of the bimanual I&A. The iris is a little bit elastic and trying to come out. So I'm just going to use a little bit of intracameral agent like the phenocaine just to ensure that the tone of the iris improves. The pupil dilates a bit. So I switched on to bimanual I&A to just go and try to aspirate all the cortex. So I can reach to the peripheral part of the capsular bag and I'm trying to aspirate. The loose or thinner cortex is being aspirated, but the cortex which is thicker in consistency, just like the epinucleus, it is difficult to aspirate with this very tiny opening in the aspiration cannula. Nevertheless, just rotating the nucleus loosens up the cortex in the equator of the bag and then it flows out. So we have a situation where the iris is not behaving very well. It is a little bit of a floppy and I'm having difficulty in decompressing the bag. Visualization is not so great. Nevertheless, rotating the nucleus with the aspiration probe itself will loosen out the cortex which is sticking on in the equator of the bag, and some of it is going to flow out. So eventually, with a little bit of a patience, you can burp out all the swollen cortex which is behind the nucleus or at the equator out of the capsular bag. Eventually, this ensures that the intercapsular pressure is reduced, and once that is taken care of, it's relatively very easy to enlarge the rhexis to the desired size we want. So time to refill the chamber with OVD and perform the secondary rhexis. Again, I'd like to prefer to place the OVD in the peripheral part of the antechamber, not in the central part where the opening is there. A tangential cut is given to the rhexis margin. Note that the scissors goes in through the main incision and you're giving a tangential cut. This ensures that risk of a peripheral extension of the tear is minimized, which is more likely to happen if you have a tear which is radial. So the rhexis could be enlarged quite easily, and now is the time to deal with the nucleus. The nucleus management is probably the easiest part in the case. The toughest was the rhexis creation, and once that is done, the nucleus management is easy because the nucleus is relatively soft. It's maybe just nucleus sclerosis of grade 1 to 2. It's very easy to chop it and make it into smaller fragments. When the nucleus is broken into smaller fragments, the fragments are pulled out of the bag and then emulsified at the level of the rhexis margin. There's hardly any cortex to aspirate. It is taken care of by bimanual I&A. Time to implant the lens into the bag. So in this case, we're performing in hydroimplantation. The bag is kept inflated with the irrigation cannula. The lens is gently implanted into the bag. The lens is dialed in. Ports are hydrated. That's it. The case is done. So in this situation where there is a shallow antechamber, swollen lens, the iris was a little bit peculiar in its behavior. Maybe it was a case of an IFIS which we didn't read it appropriately. Nevertheless, in such a situation, just using a little bit of a intracameral dilating agent improves dilatation as well as increase the tone of the iris. That can be helpful. Creating a two-stage rhexis is definitely beneficial when we are dealing with such extreme degrees of intumescence. And lastly, decompressing the bag patiently before commencing to do the secondary enlargement of the rhexis is critical. Tapping the lens around and just rotating it ensures that the swollen cortex which is there in the peripheral part of the capsular bag also flows out. So eventually this leads in complete decompression of the capsular bag, which is critical in achieving a good secondary rhexis. So that was it. Thank you for watching and hope you found this helpful.